Well, hello everyone. Now to continue our exciting the discussions for the day, I'm delighted to have here in conversation with me Faisal Mahmood, who's Vice President of Medical Oncology for International Developed Markets at Pfizer. We're here to discuss some of the themes we've already touched on. The disparities and inequalities in cancer control and cancer outcomes, but also the role of innovation in trying to resolve those. And so I think let's dive straight in, Faisal, and just what are the inequalities? What's the pressing need here in Europe? And then we can get on to the role of innovation.
No, thank you. I'm happy to join you for this discussion, and thank you for having me on. Talking about inequalities and access to multidisciplinary care across Europe and the disparities and the underserved populations is something really close to my heart. At Pfizer Oncology, we are genuinely committed to developing and advancing innovative medicines wherever we believe they can make a genuine, meaningful difference for patients. But of course, we recognize and are completely cognizant that breakthrough medicines, breakthrough innovations in healthcare are of little use if they can't reach people who need them, and especially if their healthcare systems can't afford to pay with them. And we know as that we believe that we are more than discoverers and developers and distributors of medicines. We believe we're partners in the delivery of healthcare, and that we believe that industry has an important role to play as a stakeholder, along with governments, policymakers, and patient advocacy organizations, of course, to ensure that the underlying causes are really understood and a multi-pronged approach is developed to advance care equitably. I think what we've seen, and something that I saw as actually just when I joined industry from hospital medicine, and one of the reasons I moved into oncology in particular was just the unprecedented speed in oncology innovation across the board. With all the potential druggable targets that have been created, the advantages in surgical techniques, the advantages in radiation oncology, it was absolutely fantastic to see. But I remember distinctly when I first joined, I saw a transformational piece of data where a third generation traditional cytotoxic chemotherapy agent from many years ago could reduce the size of inoperable liver mets into operable liver mets. And this would have a transformational potential impact for a proportion of patients who otherwise were going to have a very dire prognosis. But I remember thinking that the months and months and months, and in years in some cases, it took to actually spread that innovation from very specialist tertiary centers of excellence in a few countries to other tertiary centers of care in the same countries, let alone in other countries across Western Europe and around the world, was heartbreaking. It was absolutely heartbreaking. And unfortunately, that's not a one-off. It's not a one-off that we've seen. And the adoption of innovation and our role in making sure innovation in general is adopted is an awesome responsibility. It's a responsibility that we take very, very seriously. And you would have seen, and everyone have seen, the investments that have been made by innovators in making sure the right data is generated, the right data is synthesized and packaged in the right way, and that we are continuously learning from data for the benefit of each patient, knowing that each other patient who received that innovation, the learnings from that is passed across. Yes, that's my sort of opening piece. We can talk a little bit more
Yes.
specifically about Europe if you want.
Yes, yeah. I mean, I'd be interested to know. So I think in many ways, you set out a very compelling case in that that the science is exciting, that the developments in innovation across the board, as you say, are exciting, and yet may be made worse have been made worse by the pandemic, in the sense of backlogs in cancer diagnosis and in cancer treatment, has really impacted, made what you've described even worse. So I think the question is, what are the disparities in Europe? Where are the principal ones? And also, I guess they've been exacerbated. So how do we it was already, you described some problems. How do we not only restore, but improve our cancer control, use this opportunity to actually improve and overcome some of those issues that you described around the spreading of good quality and valuable innovation?
No, absolutely. And in this area, as with other area within scientific innovation, data is king. And a lot of data has been generated, and you would have seen the analysis from the Time to Patient Access Initiative, which is supported by FPA, which looked at three key dimensions, which is market access, time to market access, and patient access. Market access, we know, is a kind of a binary situation, but for the same medicines or the same innovations, in terms of the reimbursement through social healthcare systems with the same data, can vary from less than 10% to more than 90%, which is absolutely astonishing. The time it takes to get through those hurdles can be as low as a couple of months in some countries to a couple of years in other countries within Europe, which is incredible. But I think the thing for me, which is the most shocking, is the level of patient access. So once you have got over the reimbursement hurdle for innovation, once you've actually got to that point, in that first full year of formal reimbursement, the range of access for the same patients across the country can be just over 20% to just over 80%. Absolutely dramatic variability, which is really, really disappointing. So I think these key differences really undermined the shared desire between the innovators and obviously patients, and the ambition to really promote equal access for healthcare opportunities for patient outcomes is really, really important. What are the things which are exacerbating this? Now, I think there were already some systematic issues, some systemic issues. There was the suboptimal healthcare infrastructure, and in particularly the lack of defined oncology care pathways. And in those countries
Mm.
which already had suboptimal healthcare infrastructure and a complete lack of a framework for the oncology care pathways, the pandemic, the COVID pandemic, is going to have a dramatic effect. Even those countries where we've seen, for example, like in the United Kingdom, where they had a fairly well-defined oncology care pathway and pretty good infrastructure, the pandemic has had a dramatic effect on core delivery of therapies for patients with cancer, but in particular, the uptake of innovations and innovative treatments has now been set back months and months and months, and maybe years in some cases. And that's something where a lot of energy needs to be placed by all the stakeholders on these national cancer plans. Really, really important to look at every aspect for these patients, as we all know, all the way from screening, focusing on early detection, diagnosis, and making sure rapid diagnostic centers are available, especially because of precision innovation. Precision medicine really requires sometimes quite complicated genomic tests which need to be done very rapidly. That's going to be really, really important. And all of this is going to be absolutely critical to ensure optimal adherence of these therapies if they are given, but also improving the outcomes. We already know that this is an issue within countries within Europe, but we also see already before the pandemic, saw a dramatic difference between Central and Eastern Europe and Western Europe, for example. And that was the main focus of this kind of pan-European cancer plan, to try and reduce those disparities which exist. So we know lung cancer, for example, there's been some really important, dramatic incremental improvements in prognosis for patients. The mortality rate in Hungary is over 80 patients per 100,000 inhabitants, whereas in Western Europe it's just over 50. Cervical cancer, which has been in the news recently, people have seen in Romania, the mortality rate is almost 15%, whereas the European average is less than 4%. So we already see in some very specific cases some dramatic differences, but in general, survival rates are about 40% difference between Western
Mm.
Europe and Central Europe, which is pre-pandemic situations, and it's really heart wrenching to see innovations across the board. Be that radiotherapy, be that novel surgical techniques, be that novel medicines or other aspects of digital health, them not being available to all patients all the time across Europe. And creating a national cancer plan, a cancer control plan as a policy priority is absolutely critical now.
Mm. So it's interesting because what in many ways what you're pointing to, and what I want to explore in our remaining time, is the responsibility of industry of the pharmaceutical industry seems now you're arguing is it's beyond the development simply of products and medicines, although that's clearly core, but saying we want access, we want adoption, but we actually want effective adoption, which also means having a view to the rest of the pathway of care, the infrastructure, the quality assurance of all aspects of care, even the prevention and the early detection part of it, so that your medicines can be. Is that right? And how? What do you see industry, and both Pfizer and other industry partners, doing to engage beyond the production, the R&D around pharmacotherapeutics?
No, absolutely. I mean, I think there's some very straightforward things which we can advocate for and to champion, which are ensuring countries have stable financial resources and investment in human capital, a strong organizational framework, clear orientation and communication, which is what you would expect. But I think what we can bring from an industry perspective, which is quite unique, is the ability to use data and to use data to make the right decision at the right time, how to generate that evidence in order to orientate any actions that need to be taken. And you would have seen the massive and tremendous focus on patient centricity over all aspects of the development of a medicine and then a commercialization of a medicine. I think that can be transported, that 360 view of a patient, into the healthcare system. I think
Mm,
we would have seen the dramatic success of the recovery study, the COVID recovery study in the UK, and how setting up a clinical study was and using some very smart techniques and pragmatic techniques to recruit into that study and get those answers out is so dramatic. We have a lot of learnings from the development of novel and even traditional cancer research studies, which
mm,
can become directly applicable to how patients ultimately get those medicines. We've seen barriers in terms of finding the right type of patients, those underserved patients, those patients who are from ethnic minorities, elderly patients, rural communities. We've seen how it's been very difficult to get them represented within clinical studies. I think very similar confidence building measures and innovations that we've done to try and recruit those patients into our clinical studies, so they most closely match the patients who ultimately will get the studies or get the therapies rather, is something that can be directly transported to healthcare systems and really help with the appropriate adoption of innovations and integration within treatment pathways.
that's really interesting. That's fascinating. Sort of silver lining to what's been a dark cloud. What I'm interested in this issue of patient centricity in the sort of R&D and rollout of. So can you point to any sort of specific examples of how that's being used, to make sure that to make sure that the end result is indeed serving patients to the best that we can.
Yeah, I mean, there's been a huge amount of effort to really ensure the patient is involved in every aspect of decision making around what the treatment will be, and then ongoing management of their disease, which helps with adherence, which ultimately helps with safe adherence, and it helps with their outcomes. I think a lot of very interesting energy that's being placed now is around patient activation and the role of really understanding patients' beliefs around their disease, patients' beliefs around the medicines, patients' beliefs around the surgery they may get or the radiotherapy, especially for cancer patients, how important it is to appropriately activate the patient based on their educational background, their ethnic status, their educational level, where they live, and how that can have a dramatic difference and change in terms of what treatments they adopt, how they adopt them, and ultimately the risk benefit of the medicines with them. There's a lot of learnings that we're doing because we want to really make sure that the patients who come onto our clinical studies are appropriately activated, feel that this is part of the treatment so they can have the best possible outcome, and we can learn as much as possible from them. We're trying to extrapolate that as beyond the pill solutions within pharmaceutical therapy to help those first few years worth of patients who get the therapy until it gets very widely known. I think there's a lot of things that we're doing there around activating the patient, personalized activation of patients, which should be incorporated to these national control plans. And we've seen several toolkits that have been built from different organizations, for example, the Advanced Breast Cancer Coalition Alliance, which are moving in this direction, and I would highly advocate for that.
That's interesting because when we talk about innovation, it goes um, beyond innovation in drug development, but you're actually talking about innovations in, well, holistic innovations in activating patients and engaging them in their own care, and and when you talk about personalization, it goes beyond precision medicines. You're talking about personalization of the whole experience for patients. That's very, very interesting. I think we're pretty much out of time, but any sort of final comments that you want to leave us with before we close up, Faisal?
Yeah, no, I would just say that this is such an important piece because, as I said, I stay up at night thinking about what more I could do and what more data I could generate or synthesize around the medicines which are in my custody, late stage development medicines, which would, as quickly and efficiently as possible, make them an option for patients who have that disease. And in cancer patients, these patients can't wait. And I think it's such an important aspect. The worst thing you can do is have a great drug with great registrational data, but no one can actually get access to it and use it. That's what we're trying to overcome. The next big stage, of course, which will trump a lot of this, will be the genomic revolution and the move from where a lot of pharmacogenomics, which is being developed to try and create that ultra precision pharmacogenomic therapies, has been based on European ancestry genomic data. We need governments involved and policymakers involved to really generate this data across all different types of ancestries across the world, and that will require all stakeholders, including patients, to be involved, and hopefully the European Commission will help with that.
Thank you, Faisal. And indeed, these are matters that we will be discussing in the days ahead, and front and centre of that will be the Beating Cancer Plan, the Cancer Mission, and the associated initiatives, which speak to many of those concerns you've talked about, Faisal. So, look, really, really great to have that conversation with you, and I'm really grateful for your time and your input into our discussions. So, thank you very much indeed.
No, thank you, and have a great rest of the meeting.